Okay, it's noon, so we are starting. So first of all, I want to introduce myself. I'm Bia Carlini, and I'm, among any other things, in Northwest ATTC, I'm also the webinar coordinator, and who will be hosting this webinar today. As the slide says, and I'm sure these questions will come up during the webinar as well, we are gonna put both the presentation recorded and the slides available later in our website, and it will be ADA compliant, and you are welcome to get it, download it, see it again, and or refer to your colleagues. The other thing I would like to say that the slide also says is that questions can be typed in the chat box at any time. We'll take them in the end of the presentation. We really realize that we have a diverse audience here, and an audience that not only is diverse, but also works with a diverse population. And we recognize words matter, and we try to respect diversity. If you have any comments or suggestions about this webinar in this regard, please contact us. There is an email address there, and we hope you give us feedback so we can continue to try to do better. And let's now go to our presenter today, Dr. Marian Wilson. We'll talk about pain management and opioid use disorders. And she's a registered nurse and assistant professor of Washington State University. So this university is also in Washington State, as the name says, and in the Spokane area, which is the east side of our state. She's certified in pain management nursing from the American Nurses Credentialing Center and the American Society for Pain Management Nursing. She's also core faculty at the Washington State University Program for Excellence in Addictions Research and has received funding from several federal organizations to study topics such as opioid dose effects for adults with chronic pain, pain in sleeping veterans, and pain in opioid use training in rural clinics. So we are very happy to have Dr. Marian with us today, Dr. Wilson with us today, and we'll now transition to her, the slide, so she can start her presentation. Welcome.
Thank you so much, and thank you for everyone who's here today. I am going to be trying to convince you that pain is an important part of care for opioid use disorder populations. Through some of the research that I've done, I've come to believe that we need to treat the addiction and the pain. So I'll share with you some of the findings from our studies. Okay, whoop, the slides have just gotten much bigger. There we go. So I want to start back. About a decade ago was the first study that I did that really caught my interest in the chronic pain and opioid use conundrum, as it's been called by the Institute of Medicine. We had a program where we were trying to limit the number of people returning to the emergency department in a community hospital for reasons of chronic pain or people that were asking to receive opioid medicines. So a program was implemented and we studied its effectiveness and found that we were able to reduce the number of people coming back to the emergency room requesting opioids. And part of the strategy was to connect them with community resources, primarily primary care providers, and also addiction services, pain management services in some cases. The program was considered to be quite a success because we did have this reduction in visits, and the organization felt like they were saving a lot of money because of that. Because a lot of the people that would come visit did not necessarily have great payment plans or insurance coverage. But I was concerned about the people that were leaving and wondering whether they really were receiving the kind of care that they needed and if the referrals to the community were actually helpful. So we did a follow-up study, and we found that in fact those people who had come into the emergency department seeking help for their pain and or requesting some opioid medicines were not really doing much better 8 weeks after that visit to the emergency department. They had levels of pain and levels of depressive symptoms that were not really improved over time. So it suggested that there were some gaps either in the care they were receiving in the emergency room or maybe the care that they were receiving in the community. We did also find that more than half of them had a major depressive disorder symptoms, and they were not really improved in 8 weeks, which would suggest that they weren't really being connected to all of the services that they might have needed across that period of time. So that became the impetus for a lot of studies that I've been doing since then. And my high curiosity is about who those people really are who come into the emergency department and other clinical settings requesting and asking for pain medicines. We know that there's a lot of stigmatization that goes along with that population now, and there's a lot of language that's used. I usually ask in my presentations for people to share with me any terms that they have heard because it seems to be a little bit of a moving target. But when I was doing this study in the emergency department, frequent flyers was the term they used, and they even had a little notebook where they would keep track of who those frequent flyers were. I've heard drug seeking, you've probably heard that term, non-compliant or non-adherent patients. The word addict has floated around. Most recently, I had a person share with me, they call them sinners because in the treatment group where he works, that's what they consider people to be until they get into recovery. Clock watcher, that's another term I've heard in the hospital. So when we're talking about language, as was mentioned in the introduction, we know that these terms are really quite stigmatizing and carry a lot of judgment with them. So I would just encourage you to be on the lookout for terms that you hear in your settings. And I would challenge you to think about if there's any way you can help people to use terms that would be more respectful and appropriate. For example, rather than drug seeking, maybe it really should be treatment seeking. If they're coming to you and asking you for something, whether it's an opioid medicine or something else, they're really seeking some kind of treatment. So maybe treatment seeking would be a better term to use. One of the things that I heard when I was recruiting for my initial studies from primary care providers was that this population of chronic pain patients who use opioids are all addicted. They just don't know it. They're all addicted, they just don't know it, was what I heard from several providers. And that really piqued my curiosity because I thought, well, is that you know that they're addicted, but you're not talking to them about it? Or is it that you don't understand the difference between addiction and physical dependence? And I'm still curious about that. So I do try to include some definitions whenever I talk, just to make sure everyone understands what some of these terms really mean. So physical dependence, of course, is when you will have some kind of a physical condition caused by chronic use of any substance that might cause some tolerance. So we can be physically dependent to caffeine when we need our coffee in the morning, but does that mean that we're a caffeine addict? Addiction should be used when you're talking about someone with a substance use disorder, right? So we have that primary chronic disease of brain reward, motivation, and memory. And usually it's characterized by the inability or great difficulty abstaining or controlling use of something. And generally you're going to have some dysfunctional emotional response to that as well. So if I'm not getting my morning coffee, but I'm not really having any kind of an emotional response, then maybe I'm physically dependent, but I'm not necessarily addicted to that cup of coffee, right? And then this term misuse, that is used often when you're talking about medications being used incorrectly by patients. So it can indicate that you're using drugs for a purpose other than it was intended, either taking too little or too much, or taking in ways that were not intended. So for example, maybe you're using the opioids to help with some sleep problems or with a mood problem, and that's not why it was prescribed. Now, misuse, I think that label can carry a little bit of stigma as well, because if we have pain and we're taking more medicine than we've prescribed, one may be feeling like that's what they need to do in order to manage their symptoms. But to the prescribing person, that would be labeled as misuse because it's being taken other than prescribed. So just be aware of the terminology being used and think about whether it's appropriate for the person that you're dealing with. Opioid misuse, in surveys, we find that about 11.5 million of United States adults do report misusing prescription pain relievers, meaning they admit freely they're using it for reasons other than it was prescribed or using it not as prescribed. And about 62% of those people will say the reason they're doing that is to relieve physical pain. Another smaller percent, about 12.9%, say that they're misusing them in order to feel good or to get high. And then another 24.8% say that they're using them in order to relax or ease tension. So there may be different reasons why people are admitting to taking their opioids other than prescribed. And in some cases, it may be because they feel their symptoms are not being managed appropriately without having to take that opioid other than prescribed. I think it's important to take a look at the DSM criteria for opioid use disorder. And I truly wonder whether this is going to change again in the next decade or so as we understand more about people who have been on long-term opioids for pain. Because if you read what we have here, a lot of the items on this list are things that you might see in people who are using opioids long-term for chronic pain. For example, opioids often taken in larger amounts or over a longer period than was intended. We know that with opioids being used over time, you will have an increase in tolerance, so often you may take larger amounts. There may be a persistent desire or unsuccessful efforts to cut down or control opioid use. That certainly could happen if you feel like the opioids are needed to control your pain. Craving, strong urge to use opioids. We certainly see that in people who have become physically dependent and are using opioids for pain. So just think about the criteria and how it might relate to people who have a chronic pain diagnosis. And I think you will see there's some overlap. We do have this note at the bottom saying this criterion is not considered to be met for those individuals taking opioids solely under appropriate medical supervision. But I still feel that there can be some judgment or opinions that can enter into this picture. And so I'd be really curious to hear from any of you who are in the position to give that opioid use disorder diagnosis, how you are able to feel confident in giving that diagnosis to people who have a ongoing chronic pain. Because there's a lot of issues in the pain community right now where, for example, if they cannot find anyone to give them opioids for pain and they've been using it for a long time, they may find the only way they can get access to opioids is through a addiction treatment program. So some are having to make the decision whether or not to accept that diagnosis of opioid use disorder, even if they don't truly believe that's their issue, just in order to get access to their opioids. So I just think it's an interesting time as we try to sift and sort through the people who have been on long-term opioids and who are now being encouraged to stop or curb that opioid use and how we're using that label of opioid use disorder. We have seen the heroin-related overdose deaths increasing over the years, and you're probably very familiar with the statistics showing that the more we prescribe opioids, the more trouble we have with opioid overdose, and the more illicit substances have been used. But I think this very sharp spike in heroin since about 2010 and on is very pertinent to think about, and especially if you spend any time talking to people in medication-assisted treatment programs, as I do through much of my research, and you'll hear many anecdotal reports of people who have gone out to find heroin when they have been cut off from their opioids that they've been taking long-term for chronic pain. So we can't say exactly what happened to cause that spike, but I certainly think a contributing factor can be the people who started to have less access to opioids through legitimate means and so felt compelled or forced to find relief through heroin. And I'll tell you a little bit more later in the presentation about what some of those folks have told us about their transition from using opioids for a chronic pain condition to now being treated for a opioid use disorder with medication-assisted treatment. My program of research really focuses on advancing the science for undertreated symptoms in adults with chronic pain and opioid use disorder. because we know there's a lot of issues that they deal with that can impact their quality of life. Often, both populations will struggle with undermanaged pain, anxiety, mood disorders, depression, sleep problems, withdrawal symptoms. Even if they are a chronic pain person that is not diagnosed with opioid use disorder, they may suffer withdrawal if they don't have access to their opioids, and often some GI problems, of course, can occur both with withdrawal and with the constipating effects of opioids. So there's a lot of treatment that needs to be provided to people using opioids for either pain or opioid use disorder, and a lot of opportunities, I think, to do better as far as managing their symptoms. We do know that symptom management can greatly influence a person's perception of their overall quality of life and their ability to function in society. So I'm very interested in helping people find access to treatments that work well, and particularly helping people access some of the non-pharmacological and behavioral therapies that are not necessarily a first line of approach for some of these symptoms. So just to refresh, if you're not aware of the definition, pain is an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage. And this is important to recognize that pain is not just the sensation of pain that a person feels, but it's also all of the emotions that go along with that pain. And I have come to believe through most of the research I've done that this emotional aspect of pain is where we can do a great deal more in helping people cope with their pain. And I've worked with populations who have chronic pain in primary care, and then also who have chronic pain in opioid treatment programs, and would postulate that pain is really no different for people with a substance use disorder and should be recognized and given its due diligence as far as helping people to manage that pain. But we do know that for people in medication-assisted treatment for opioid use disorder, and by that I mean they'd be receiving methadone or Suboxone or buprenorphine to help manage their daily desire or cravings or withdrawal symptoms with their opioid use disorder. For those folks, we do know that many of them do have a persistent pain problem. 60 to 80% will complain of pain. Many of them will have pain associated with their withdrawal, and many of them do come to use opioids for the first time because of a painful condition, and even for emotional pain. So there's a lot of pain in this population. We do know that generally pain management is not part of a medication-assisted treatment program. In fact, many people will say that it's not meant to be part of medication-assisted treatment, that that's really just a focus on addiction. And we also know that people do show up in medication-assisted treatment who have a chronic pain problem. I heard from one participant, she described it as my doctor kicked me to the curb. And we certainly see a lot of difficulty right now finding providers who will continue to prescribe high-dose opioids. There's a lot of scrutiny on people who want to provide those prescriptions, even if it's being done legitimately. There's a lot of risk involved for the provider, and there's a lot of pressure to reduce or take people off of opioids. And what I've heard from the patient populations is that sometimes they're really caught in the middle of this, where they've been managed under a provider's care for a long time receiving opioids, but all of a sudden the doors are closed, the clinics close. I've seen several clinics closed right here in Spokane, and those patients are left with nowhere to get their opioids legitimately. So it is a real problem. And I guess what I'd really like to see is for us to get just as upset about people who are abruptly cut off of opioids and left to suffer withdrawal and potentially have to seek out illicit substances, as we are about people who are prescribing in a way that we don't think is appropriate. There's a lot of scrutiny on the providers about how they're prescribing, but I think there's less alarm about all of those people that are not receiving opioids when they have been receiving them legitimately for years. So I think that's a real area that we have to fight to have some advocacy for these patients. And I feel like that's part of what I am trying to do with the research that I've been conducting, just hoping to shed some light on what's happening for some of these patients. We do know that pain can significantly affect the outcomes with addiction treatment. The treatment, when you have pain and you're in medication-assisted treatment, is complicated because you often have a heightened sensitivity to pain. So maybe opioids are not going to work quite as well for you. You could have a high opioid tolerance. If you do have a pain event, an acute pain, and you show up in a hospital, it can be a much more difficult person to manage as far as their pain. They may be using illicit substances, which complicates things even further as far as, how those medications and drugs might interact and any risks associated. And there is this feeling that I have heard out in the treatment communities that we need to stabilize the addiction before pain can be addressed. And in fact, I heard this quote in a webinar that I attended from a provider who said, "We will treat the addiction, not the pain," when we're talking about medication-assisted treatment. And I do understand that when you're prescribing medications in medication-assisted treatment, it is meant to target the addiction and the withdrawal symptoms. It is not meant to manage the pain. But I would suggest that we also need to acknowledge that when a person is suffering with withdrawal and with opioid use disorder, they're often experiencing pain concurrently. So it's not something they can put off until tomorrow when I'm going to see a pain management specialist or whenever I can get in to see someone. It's something that really should be incorporated into part of their care, and it should be addressed in some way if we really want to make a difference in their overall recovery. There are some pain care standards. This was from 2014, and it says that people who have pain and addiction, any kind of addiction, they may continue to be treated for pain with non-opioid medications and non-pharmaceutical agents. However, they are at risk for overdose and until opioid addiction is adequately treated. And to this, I would just add that I feel they are also at risk for overdose if their pain is not well treated, because we do know that people will be seeking opioids to try to relieve their pain if it is not addressed. So when you're talking about how then to help people manage their pain if they're already receiving opioids, or they have an opioid use disorder and they don't wish to use opioids, or they're trying to stay away from opioids, there are lots and lots of things that can be suggested and added to their care that can help them. And I'm showing you here on the screen the things that have the highest evidence as far as complementary therapies for chronic pain, and that could be encouraged and implemented along with any kind of opioid use disorder treatment. So cognitive behavioral therapy is a very old, well-established treatment for chronic pain. We can absolutely help people by teaching them coping skills to learn to manage their thoughts and feelings related to their pain, and that can impact their overall perception of pain intensity. Exercise, physical medicine, time and time again, is shown to be helpful. Particularly things like yoga and Tai Chi are very helpful for people with all kinds of pain. And self-management or pain rehabilitation, these kinds of programs, there's lots of evidence out there in the literature showing how well they work, and they can look different. They can come in all kinds of different packaging. They can be an outpatient intensive program. They can be an online program. They can be groups. So there's lots of different ways that you can deliver self-management or rehabilitation. Somebody just asked about CBD oil. I'll be talking about cannabis just briefly at the end of the presentation. I do want to point out that the new CDC guidelines in 2016 have recognized that multimodal, multidisciplinary biopsychosocial approaches to pain are the standard of care. And so it should be something that people can access. We also know that sometimes these multimodal approaches are difficult for people to access, in part because of the healthcare structure, payment, insurance, reimbursement kinds of issues and barriers that people come up against. And we'll talk about that a little bit more too. So I want to focus on self-management because that's really where I've focused some of my research in trying to help people access some self-management skills. We know through lots and lots of research that Dr. Albert Bandura and others have worked on for years that this feeling of self-efficacy or confidence that you can carry out a behavior is very strongly related to the ability to improve physical and psychological functioning. And particularly for people with pain, if we can boost their pain self-efficacy, if we can help them feel that they can manage their symptoms, we have very robust evidence showing that this will lead to better functioning, ability to return to work, improved mood, improved quality of life. So we know that it works. There's lots and lots of evidence out there to back it. Do we know if this concept of self-efficacy would also apply equally to people with substance use disorder? We do. There's some evidence on that as well. There's research that's been done. So it logically follows that if we can boost pain self-efficacy within people who have a substance use disorder, we can improve some outcomes for them as well. So I'd like just for you to think for a minute about how we can help move from an opioid-centric paradigm in treatment for people with pain to one that can use other modes of pain management. And I'm using this term self-management, really taking it from Dr. Kate Lorig, who's done decades worth of work on this topic with the chronic disease self-management program out of Stanford. What you see in the boxes are some of the main components that you might find in a very inclusive self-management program. But again, these programs, they can take different forms, they can look differently, but basically they should have the tasks that individuals need to live with their chronic health conditions. So generally there'll be some kind of goal setting where we expect people to adopt some new behaviors and skills. There will be some building of confidence. This theory of self-efficacy is at the center of self-management plans. We have to address cognitions, address the thoughts and feelings that go along with whatever the disease process might be. There's usually some social support and some group support or group persuasion component, and quality of life is going to be wrapped up into that relationship and social support box. And then there's generally some education where we might be talking about how they were going to adhere to a treatment plan or increasing their knowledge about their disease condition. So I think this model fits very well for pain self-management, and I would just encourage you to think about how the same type of model might fit within substance use disorder treatment, because it's not something that you necessarily see presented very often in this kind of a way. So we did a randomized controlled trial. It's been just a couple years now. You can read the full paper if you're interested. But we tried this online pain self-management program focusing on people receiving medication-assisted behavioral treatment for opioid use disorder who also had a concurrent pain. And the majority of participants that we recruited did report that their first use of opioids was in response to a painful event. Some of them qualified that as a emotionally painful event, but for most it was a legitimate physical painful event of some sort. I do want to point out, just because we were receiving our population for this study from an opioid treatment program, and they did consider themselves to be addicted to opioids, that doesn't mean that everyone on opioids are addicted to opioids. I'm talking about a subpopulation who already have identified themselves as having a substance use disorder and also have a concurrent pain. We recruited from an outpatient setting where most of the patients were on methadone, and many of them were still coming in daily for their dosing. Some of them were earning the privilege to take home their methadone and dose at home. The purpose of the study was to understand more about the status, really, of those who were in opioid addiction treatment with coexisting pain, and to pilot test this online chronic pain management program in a new population. I had done a previous study with my colleagues here at WSU, and that's been published. You can read that study if you like, but we had tested the online pain management program in a group of chronic pain patients recruited from primary care. We found through that study that yes, indeed, pain self-efficacy was improved, and we did see some reduction in opioid misuse behaviors that were reported by people who engaged in the program. We've taken that study as preliminary data for a larger study now funded by NIDA, where we are testing the same program on patients from chronic pain primary care populations, and we're able now to look at its effect on their morphine dose. So we'll have access to the clinical charts, and that's in its 4th year, I think now, and we'll probably be able to have some papers coming out on that study in the next couple years. So this study I want to tell you about, though, in the opioid use disorder population, we did a small sample in a clinic randomizing people to either experimental treatment with the chronic pain management program or an attention control waitlisted group. This is just a screenshot of what the program looks like. It is a web-based 8-week pain self-management program, and it's based on CBT concepts. Here's just an example of one of the learning centers, Thinking Better, which is designed to help address and recognize self-defeating thoughts, negative thinking related to pain, and catastrophic thoughts such as, this is the worst pain I've ever had, helping people really recognize when they're having those extreme thoughts and trying to replace those with more helpful thought patterns. So all of the learning centers have a video overview, so you can just click on the screen and listen to some information, and then they have these interactive activities that you can click on to engage more directly in things that are unique to your own condition. The program also has a navigator where you can check in daily, rating your pain and your mood and your activity level. There's a calendar where you can add activities to try to make goals for yourself and meet those goals. This is just a flow diagram of our enrollment. We ended up randomizing 60 people. We had a bit of attrition as we expected with this population. It's never an easy population to keep in studies, and we ended up with 22 analyzed in attention control and 17 in the treatment group. We used a computerized survey system, and we did give some prompting to engage in the program, but we didn't spend a lot of one-on-one time really hand-holding and to help them through the program. We did offer some hours in the clinic where people could get some orientation to the program, but they were meant to complete the activities pretty independently. We did look at pain and depression, anxiety and withdrawal, and opioid misuse measurements at the 4 and 8 week time point. We expected the program to have some improvements after 8 weeks, as it has in other studies. And then we did offer the waitlist the opportunity to try the program if they wanted. We did end up with a group that had 53% male, which was really fantastic because many of these studies, it's very hard to recruit men, and there usually are more women than men in the chronic pain studies that you'll see. The average age, 44 years, that was about the same as what you'd see in many chronic pain population studies. We did have about 13% Native American, but otherwise we don't have a lot of diversity here in Spokane, so it did match the diversity of the city that we were recruiting from. The primary pain diagnosis was very similar to what you might see in a normal chronic pain study population, whereas spine and back problems often account for the highest number of people with a pain diagnosis. Nerve pain, post-surgical pain, fibromyalgia, those were at smaller percentages. So I wanted to share with you here, overall for the whole group in this study, we measured their symptom burdens over time, and you'll see on the gray bar is the pain interference and the red bar is the pain severity. The baseline and the final scores for both groups were above average, so a 5 or a 6, which would be a moderate level of pain. And you'll see that over time, those didn't really seem to change very much. You'll see a similar pattern in the baseline and the final group as far as their depressive symptoms. And on average, they were almost to the moderately severe level, so pretty high burden of depressive symptoms from the beginning to the end of the study. And again, with anxiety, we'll see that many have pretty high anxiety level to start, almost to the severe range, and that decreased just a little bit over time. The only significant improvement for the full sample over time was in the withdrawal symptoms. We use the ARSW, which is a self-reported withdrawal measurement. And these scores were of interest because if you look at it in the literature, you won't usually see scores quite this high. So to me, I was very interested in what kind of withdrawal symptoms they were having. So looked at the items a little bit more closely, and the most common symptoms that had the highest ratings were the ones that you'll see listed on the screen. So muscle cramps, painful joints, trouble getting to sleep, irritable and fitful sleep. Two of them here about sleep that were important. And I've used this information to help direct some of the present research that I'm doing, trying to understand more about the sleep disorders within the opioid use population. So the main findings of that study, those who engaged in the program did improve their self-reported pain severity, pain interference, and pain self-efficacy. They did have report of reduced opioid misuse behaviors and reduced depressive symptoms. But to me, what was important to note was that the symptom burdens were pretty high, even though these were often people who were having a lot of contact with clinicians because they were coming in daily or frequently to the clinic, which made me feel that maybe there's just more opportunity here to help manage symptoms within this population. We did find trouble with many of them in engaging in the program as we expected. Many were anxious, many were experiencing withdrawal symptoms when they came into the clinic, and then were having, effects of their dosing, sometimes a little bit sleepy right after their dose. So engaging them in the program was not easy. Many had barriers of transportation. Some had never used a computer before, had never used email before, so we were teaching them, how to do that and helping them set up email accounts. So that was difficult, and just being motivated and keeping motivated. We didn't give them any kind of great reward for engaging on a day-to-day basis. If they stayed in the study, they did receive a small monetary compensation, but they didn't receive anything based on the activities they completed or their engagement in the program. So we did find that when we gave them more reminders and we offered them one-on-one time, that seemed to be helpful. But we did feel that they probably could have used a lot more support than what we had planned to give them. The satisfaction with the program was high. Most of them were pleased, thought it was easy to understand. The ones that did engage were satisfied with the overall ease of the program. From this, we did another study. I have a picture here of my teammates here, Dr. Michelle Shaw and Mary Lee Roberts, a PhD candidate here at the College of Nursing. We wanted to understand more about the process involved when adults first initiated their opioids through their treatment in a medication-assisted treatment program. So we did some interviews of the people in our randomized controlled trial to learn more and used a grounded theory qualitative approach. We really wanted to hear more in their own words about how they were living with persistent pain, what the opioid medicines were doing for them, and their eventual decision to enter the treatment program for opioid addiction. So we ended up with 10 people that we selected at random from the people who were in the initial study. And we did develop a new theory that we titled Living with Persistent Pain from Opioid Initiation to Substance Use Treatment. We found 3 predominant categories that I'll go over a little bit, how the participant data supports these 3 predominant categories in our final figure of the theory. So relationship spectrum, people talked about supportive and non-supportive relationships. Living with pain is central in our theory because we heard about that in great detail, how that really influenced their everyday life. And then they talked about their pathway to addiction and how they felt they were becoming normal. So with the pain, here's one quote: "There's no trap door. There's no out from it, the pain. There's things that help, but it's always there. I start thinking about that fact. Unless something changes, this is going to be here for the rest of my life. That's when I start getting depressed and feel hopeless. It creates a lot of underlying stress when you have all that pain all the time. It makes you feel almost claustrophobic." Then they talked about relationships. Some were supportive and some were not. This person is talking about a controlling boyfriend. With the pain pills, he knew that was a big way to control me in the ways that he wanted to. It seemed like he was supporting me and loving me and everything, but after a time, I saw it wasn't really support or love. And here was a quote from a supportive relationship. "There was a reason they, providers, didn't let me die. My cardiologist came in and saw me and he told me, you're going to the methadone clinic." "Oh, I am? I'm not asking you. You're going. We can't have this. I'm not going to have you die. Not after everything we've been through. We're not doing that. So you're going to the methadone clinic." So that was identified as a supportive relationship from a provider. And then we heard of some non-supportive relationships from family. I hear from my family, when are you finally going to get off of that stuff? And I tell them, you know, I might not ever be able to get off that stuff, methadone. So, you know, they don't understand the maintenance part of the methadone. Another unsupportive relationship was reported by a doctor. The first thing my doctor told me was, don't expect to get anything from me, pretty much, which is wrong. I mean, that's totally wrong. I can't get past that to address all of my pain issues. So then they were talking about the process that eventually resulted in opioid misuse and addiction. What most often began as a prescription for a medical issue commonly turned into participants misusing opioids by increasing the amount and frequency of medications that they used. The three supporting concepts in this category were opioid initiation, craving, and transition into dependency. So one said, I was actually just about to turn 18 years old and I was in a car accident. I got set up with the doctor and he started giving me pain pills for it. I think it was like a year and a half later and I was still on those pain pills. I wasn't really given any other options than chronic pain pills and opioids for it. I gave birth to my fourth pregnancy and my sacrum was fractured and it never healed. It was interrupting my day and night, my life in all facets. I was given opioids for the pain. Here, we're talking about the concept of craving, and they talked about this consistently throughout the transcripts. And it was just like this loud, not a voice, but you know, just this loud thought of just go get the pain pills. It will fix this, because it was such an debilitating thing and such an unwanted feeling. It was just like one of those hamster wheels. It seemed to never stop. Getting off the hamster wheel and thinking, my brain would tell me, you know, this pain can stop if you just go get pain pills. And here, the concept of transitioning into dependency, they would say, when it comes to opioids, you don't realize when you're addicted until you try to quit. You know that when you're trying to quit or not take them and you get sick, it's like having the flu cause your whole body aches, a miserable feeling. What happens is we get to the point that we are willing to give everything we have to it, and we do. We give to it. We keep giving until we have given all we have to give. Then the next stage, they all talked about some turning point where they were seeking help. So one day I just said, enough's enough. I don't want to do this anymore. I decided to do something proactive and make a change. And I went out the very next day after I got out of the hospital. After that incident, I went to the methadone clinic. Continuing on, I would say 90% of the people that come to these medication-assisted treatment clinics, they just want to feel normal. Eventually, you got to the point where it was what methadone should do. Just take away the withdrawal symptoms and the cravings and allow you to wake up in the morning without having those awful cravings and thoughts. It really does help you to just feel normal. And I guess normal being not in pain, aware and alert. Not all days are rosy, but there's days I'm happy, or I'm happy in this journey of my life. So we did see some hope in the end of the interviews for really everyone who had gone through the treatment. Some of the implications that have come from this work has been the importance of discussing non-opioid and non-pharmacological options for pain early on. Many of the interviews, patients talked about not really having access or being offered options early on. Having some shared decision-making and developing realistic pain management goals. Educating patients about potential pitfalls, realistic benefits of using opioids before initiation, and often throughout the course of the treatment would be important. And assessing for substance use risk. Really, that should be done on day one of the prescription. And if they have a substance use risk, such as family history of substance use problems or childhood adversity, that doesn't mean they should never receive opioids, but it does mean that they should receive additional counseling and support if they are starting opioids for a painful event. Beginning to discuss tapering plans. I hear from my nursing students here, even today with all the attention on opioids, we still have people receiving bottles of opioids with no talk about the tapering plan. So whenever a prescription is started for a painful event, that should be part of the initiation. When are we going to stop when we start an opioid? And supporting patients throughout. Populations in MAT who have chronic pain should receive coping skills training that addresses their ability to deal with stress and distressing symptoms. So building on this self-efficacy is really important. What we heard in the interviews was this conversation about treatment options, medication-assisted treatment, counseling. It was critical that the providers started these conversations in many cases. Sometimes the participants came into treatment because of a friend or someone on the street encouraging them to go, but often it was from a provider doing that. So just the importance of starting that conversation and helping them reach their desire for becoming normal, I think is important to know. Offering hope and helping them know that these supportive healthcare relationships in medication-assisted treatment and otherwise can encourage them to have success with their treatment. So in summary from that study, we felt that living with pain as a concept is a complex and tumultuous process from the original painful experience to initial use of opioids to ongoing recovery in medication-assisted treatment. The pain did not go away just because they were in medication-assisted treatment for many of them. It's going to continue to be central to their life. The relationships that either support or detract from recovery are critical to their decision points, to deciding to go into treatment, and then also their quality of life once they're in treatment. Having people understand what this medication-assisted treatment is to provide for them and not having stigma associated with them. They all talked about a lot of stigma just as far as being part of these programs. Yet, most felt that decision to enter MAT was key to them becoming normal again. We need to continue to develop and test options to assist in managing pain within the context of medication-assisted treatment and understand that physical and emotional pain have to be addressed, and it should be with compassion in all phases of treatment. Having trusting relationships with non-judgmental support and advocacy are essential for people with pain and comorbid substance use. We have done a little bit of work about cannabis as well, because we heard from a lot of our participants that they are using cannabis to help manage their symptoms of pain, sleep, anxiety, withdrawal. And so we have published some work on this. One study that was recently published was specifically asking about opioid use disorder patients, and about half reported using cannabis in the past 12 months to manage their aches and pains. Now that it's legal in Washington state, they can do that. A few years ago, we were still screening people and not allowing it. So I expect that we'll see more and more use and possibly more problems related to use if they are going to occur as more people begin using cannabis as a way to manage their symptoms. So you'll see the most common reasons that they were using cannabis was for recreation or social, but then also for pain, sleep, anxiety, stress, and withdrawal. We did find that the frequency of cannabis use was not related to their symptom levels. So it didn't necessarily mean that the more you use cannabis, the less pain you would have or the less depression or anxiety. We didn't see any relationship there. But we did see that the frequency of use was negatively correlated to this concept of self-efficacy for managing their emotions. So it seemed to suggest that for some, they're really using cannabis as a solution for a cluster of problems: pain, sleep, anxiety, withdrawal. And in some cases, it may be that they don't really have a lot of other skills or a lot of confidence in how they can manage some of these emotional symptoms, particularly without the use of cannabis. So to me, I see this as an opportunity to help people develop some of these coping skills using CBT kinds of methods and really helping to boost their self-efficacy so they can manage some symptoms with or without additional pharmaceuticals. So we have a current study underway. We have finished some preliminary studies looking at hyperbaric oxygen on its effect on withdrawal signs and symptoms, and recruiting people from opioid use disorder. So we continue to do some work around that. We did just have a published abstract on that, and we showed this at a recent conference, showing that the hyperbaric oxygen therapy could be improving sleep, and maybe that would help people with their methadone dose reduction goals. Another issue with the medication-assisted treatment that we're seeing is that a lot of people are getting started on it, but there's not necessarily an exit plan. And we have a lot of folks, very young, who are in medication-assisted treatment, and they're 20 years old, and you have to wonder what we're going to be talking about in another 30 years if we don't have any kind of an exit plan for some of these people. I do recognize that it can be very life-saving and important to help people begin recovery, but I think also thinking about the long-term plan for some of these folks is an important area to continue to study. So in closing, I just want to make the point that symptoms are not insignificant. As this quote said from a study or article done in 2017, when their last dose of drugs starts to wear off, they'll take anything to avoid withdrawal, which they describe as the flu on steroids with fever, vomiting, diarrhea, and high anxiety. Literally, symptoms can be a matter of life and death when we know that people will go out in the streets and find things for comfort if we don't provide them some other kind of way. And so I think if we really want to address the opioid overdose rates that we're seeing, we have to acknowledge the importance of symptom management within the context of our treatment for people. I've listed some of the people that have helped with some of the projects I've mentioned here today. We have a lot of folks working on this work, so nothing I've talked about was done in isolation. And here's some contact information if you'd like to send me any questions or chat about any of these ideas. I'd be very open to any further discussion. So I'll open it up to any questions that you might have now.
Thank you so much. That was very, very helpful. So I'm taking the slides, control the slides back now so we can start questions. Before we start questions, I just want to let you know, and if you attended our webinars, you know that already. Right after we finish that, you're going to receive a request to give us feedback. It's a very, very brief survey. It really takes 1 minute to complete. It does take just 1 minute. And it's a way that we can continue the work we are doing and get feedback from you. So please consider answering them for us. If you need certificate of attendance, they are available for the live years. That means you, not if you later watch online. If you are watching in a group, then we need the name and email addresses of you individually so we can do the certificates of attendance, because all we have is the person that is registered to attend. If not, the certificate will be emailed within a week to the address you registered with. So now we have already some questions. So let's start with the question about CBD oil as an alternative, and then we go from there. We have about 8 minutes. So yes, thanks, Dr. Wilson. And can you address this first question then?
Yeah, I think we really need more research about the use of cannabis as a therapeutic agent. There's such little amount of high quality science, particularly on the products that are available to people today. Most of the studies are done on the government issue marijuana that is very low THC. So I know you'll hear from people that do think that this works. And I believe in experiments where the N equals 1 sometimes. A person just needs to try and see what works for them. I think from some of the research we've done, one concern we have is that people aren't necessarily given information about potential risks of cannabis, and there are, of course, some. So I think that if it's going to be encouraged, that people should just go into that openly, particularly now with the trouble with vaping. A lot of people are vaping the oils and things like that, so there are some risks to think about. I see a question here about does the hyperalgesia mediate at some point?
We try to go in order, so it gives yeah, just to give the opportunity to everybody. But yeah, go ahead if you rather take this one. So does the hyperalgesia? Just go ahead and read it loud so people can get it.
Yeah, I have heard that sometimes the hyperalgesia will be reduced if a person takes an opioid break. So sometimes that is a strategy used for people who are on opioids. If they can switch an opioid medication or they take a break, that hyper sensitivity to pain can be reduced. But again, there's so little studies really looking at pain within the medication-assisted treatment program populations that I think we don't fully understand how that can be mediated. for people on medications long term for opioid use disorder.
Great, thank you. There are a couple of questions here about, can you send me the slide again, email again? So I'm going to reiterate, all of this is going to be published in less than 24 hours online in our website, Northwest ATTC. Just Google, you find it. And you can find the slides, you can find the emails you need. It's all going to be there for you and available. There's another question. So number of people for whom MET does not work to control pain enough to feel normal. Not sure how that is. A cocktail of shorter acting opioids does work. And manage symptoms with psychosocial and non-mood altering pain only treatment CBD oil. Thanks so much, Dr. Wilson. Not quite sure I understood the question, but there it is.
Yeah, I think there might be some suggestions in here as well as a question. And certainly, you know, there are people who are very skilled at managing pain for people in medication-assisted treatment using some various medications that may be opioids or non-opioids. So I guess my best advice would be, if you have a person in your care who has pain and is in medication-assisted treatment, try to get them to a specialist, someone who does have some pain management certification. It can be a nurse practitioner. There's some wonderful ones that have a pain certification, and also primary care or pain specialty clinics where they can help them find other medications that could be added to their medication-assisted treatment, their methadone or their buprenorphine. Sometimes the buprenorphine or Suboxone may be better because they're long-acting, but getting people to transition from methadone to one of those drugs is very difficult. So that's a real issue that we need to try to find a solution for. And you mentioned the psychosocial and non-mood altering CBD oil medications. Yes, definitely we can do a lot with helping people with the feeling of pain interference, particularly, and that emotional baggage that goes along with pain. We may sometimes never be able to completely eliminate a pain or even reduce a pain, but we can always do something to help with the coping and the emotional side of pain. So that's where these cognitive behavioral therapy kinds of things and self-management can play a huge role in helping people live with their pain.
That's wonderful. So before we get to the last question, just heads up, we're going to have our next webinar in November 20th. It's a little earlier in the month because of Thanksgiving holidays, and I hope you can do it. So we have a last question here that is actually ours here. So can you talk a little bit more about resources to help individuals who have co-occurring pain and substance use disorder? Anything you would recommend for our group?
Yeah, there's lots of great resources. Patient-specific resources can be found through the Chronic Pain Association, the national organization for people with chronic pain. They have a good website. The United States, the U.S. Pain Foundation is another place that you can send patients for information. And then, of course, for professionals, there's the International Association for the Study of Pain. That is a great resource, and there's some physician-specific and nurse-specific pain organizations. I'd be happy to share information, or you can Google and find those. But I encourage you all, when you have people with pain in your care, just do your best to refer them to specialists, find out all that you can. There are a lot of resources available, and it's a matter of the access to the resources that is still a huge problem, I feel, in this population. And that's where our role is as, you know, providers or healthcare professionals, to try to help them access the help that is available.
Yeah, wonderful. Oh, that was wonderful. I hope everybody enjoyed as much as we did. And thanks again, Dr. Wilson. That was very helpful. And let's call the day then. Thank you.
Thank you all.